Hi, this is Dr. Ahmed Youssef, an ET and head and neck surgeon, and today we are discussing an important topic for everyone, starting from the ENT trainees until like the level of consultant who is non-head and neck and some of the head and neck based consultants as well. So we discussing today the management of neck trauma, and we'll try to make it as simple as we can. So, in terms of the neck trauma, we have two types of neck trauma. We have a penetrating neck trauma and a blunt neck trauma. To first of all, we have to review quickly the anatomy of the neck. So like there is like an important muscle dividing the neck into anterior and posterior triangle, which is the sternocleidomastoid or the SEM. Posterior there is a trapezius, and here is a posterior triangle bounded by the trapezius posteriorly and SEM anteriorly with its sternoclavicular end, and the clavicle inferiorly, and all of this have two structures here, which is most important: spinal accessory nerve and some of the big branches of the subclavian artery and vein, and the subclavian vessels down. Anteriorly, there will be a midline and the mandible and the clavicle or the sternum, actually, inferiorly, and there is an omohyoid muscle and a gastric muscle on top, dividing the neck into levels, level one and level two and level three between the omohyoid and actually like level three between the hyoid and the omo. Level four is below the omohyoid until the sternum and the clavicle. So that's basically in the midline. We have the midline structures, larynx and hypopharynx behind, and the trachea and esophagus, and the thyroid gland as well as an important nerve, which is the recurrent laryngeal nerve. So that's a resume about the basic anatomy of the neck. And if we want to discuss the trauma itself, and that's important to know where the trauma could be in the neck. We have two types of trauma, as I mentioned earlier. It's a penetrating neck trauma, where it could be a low velocity penetrating neck trauma, like a stab injury or a knife injury, or it could be a high velocity penetrating trauma, like a bullet or missiles. It's totally different when we're talking about a stab neck. It has an entry or a low velocity penetrating trauma. It's not very common. It's 5 to 10%, and it's unfortunately the mortality rate is high as 11% or 10 to 11%. And usually it is frightening for any junior ENT surgeon or an ENT non-head and neck surgeon as a consultant or a trainee. And it has to mention that the ENT team should be a part of the major trauma team, including other specialties as well, like an emergency, general surgery, and also ITU and anesthetist and vascular surgeon as well, and plastic team. Um, High velocity is a little bit different because it has an inlet and outlet, and because it's high velocity and there is an inlet and outlet of the missile or as a bullet, there will be more damage. Part of it is the heat damage, and part of it related to the mechanical speed of the missile itself. So there is a more damage happen when we're talking about bullet injury or a missile injury compared to the stab neck. However, the stab neck or the low velocity is very close, so it could be from a close distance. And then, even if the damage is smaller, it could be more serious because it could be fatal if we're talking about a vessel injury in the carotid or so. Um, so, as I mentioned earlier, the velocity of a projectile or the missile is the most significant aspect of the energy transfer, and the more speed will be the high velocity penetrating trauma with the missile. It will be the more the damage. It could be for the structures as a mechanical or a heat damage. And this is a basic diagram about the bullet injury and the inlet and how it's dispersed if it's a high speed or a low speed. And there will be a temporary cavity that could be a permanent after that, as there is an exit point. So sometimes a bullet injury can induce an inlet and outlet, and nothing in the structure, surprisingly, in the midline or the lateral compartment of the neck and major structures has been injured. lucky patients. We've seen something like some people like that. However, basically, it could be really damaging if it's going to a major vessel. Then we don't expect to be a partial injury, or a midline structure will be totally, most of the time, a complete injury to a vessel. So because of that, it could be a fatal injury. Um, be aware of the stab wound around the clavicle, because the subclavian vein is a higher risk. The subclavian vein is usually superficial and higher up compared to the subclavian arteries. That's to mention. So why we are talking about it, because the traditional thing, whenever there is any penetration into the neck platysma or a neck muscle, which is neck skin and subcutaneous tissue in the platysma, anything penetrating beyond the platysma, you should explore it. With that, it means that when the other centers did a review about it, they found there are like many unnecessary explorations happened and with no impact on the patient. Many of them has been explored and no injury actually to the deep structure happened. So it's not the case anymore, because we have now the clinical assessment and the technology by doing a CT scan or a CT angio can give us an idea if we need to explore or not. So again, to talk about briefly about the facial layer, we have the skin and subcutaneous tissue, and we have an important muscle encasing the neck, which is a platysma, which is absent in the midline. And beyond the platysma, there will be a deep fascia. And the deep fascia, as we talked about in the deep neck spaces in some of the lectures, has been shared with you guys, is three layers: investing layer of deep cervical fascia, which is a superficial part of the deep cervical fascia, which is investing actually the SCM and the trapezius, and going superiorly to be splitting around the submandibular and parotid gland. We have the middle layer of the deep cervical fascia, or a visceral layer, encasing the thyroid gland and the midline structures. Part of it is the pretracheal fascia and the buccopharyngeal fascia around the pharynx. And we have the deep layer of deep cervical fascia, which is portion of the prevertebral fascia, either an alar layer, which is going to the superior mediastinum, and also to the proper deep layer of deep cervical fascia, which is the prevertebral fascia, going around the prevertebral muscles all the way down to the coccyx. And we have the carotid sheath, which is on both sides of the midline structures, and usually encased by at least two, and we can say three of the layers. The deep investing layer is on the top, and we have also the deep layer of deep cervical fascia in the middle cervical fascia, splitted or actually fused, and to go to the deep portion of the carotid sheath. And the carotid sheath has three important structures, which is the carotid, common carotid, which is splayed or divided into the external and internal at the level of the upper border of thyroid cartilage or lower border of the hyoid bone. And we have the lateral to it is the jugular vein, and in between is the vagus nerve, and the sympathetic chain is usually deeper, and phrenic nerve deeper to this, and actually encased by the deep layer of deep cervical fascia, which means that it's unusual to be affected. This is again a schematic diagram of what we talked about as platysma, and we have the investing layer of deep cervical fascia as SCM and trapezius, and we have the middle layer of the deep cervical fascia. Sorry, this is like the platysma and superficial, that's a deep investing layer, SCM and trapezius, and we have here the visceral layer, including encasing the strap muscles and thyroid gland and trachea, and also the buccopharyngeal fascia, and we have the deep layer of deep cervical fascia, which is encasing actually beyond the retropharyngeal space as the alar layer, or the proper prevertebral deep layer of deep cervical fascia. And again, we are describing the neck into triangles, posterior triangle and anterior triangle. And the anterior triangle is subdivided into levels, which is the neck dissection levels actually, or the neck node level. Level 1A and B, which is between the digastric and the mandible. Level 2, it's beyond the skull base till the hyoid, between the hyoid and omohyoid, until the cricoid cartilage is level 3, and level 4 beyond the omohyoid. And in the left side of the neck, remember, in addition to the carotid sheath, there will be the thoracic duct on the left side, and the posterior triangle, the inferior peri of omohyoid, and we have here the spinal accessory nerve going beyond or actually penetrating the SCM at the junction between the upper and middle two thirds, and exit at 1 centimeter above the Erbis point and going posterior triangle deep to the investing layer of deep cervical fascia to penetrate into the trapezius 5 centimeter above the clavicle. So it's again a schematic diagram to just to memorize the anatomy of the neck and how the different levels can have some structures. So it's actually level one submandibular gland is there, the facial artery or a facial vein that can be a risk if it's a stab it's here or a penetrating trauma here. Here level two, it's actually like the level three is the carotid. It's actually more exposed medially rather than the jug, which could be injured if there is a stab muscle involving the external jugular first and the SCM and going deeper to the internal jugular vein. Internal jugular vein can be injured at level 4 as well, on left side thoracic duct. And remember level 5, which is beyond the SCM posterior between it and trapezius, there will be a risk of injury to the subclavian vessels if it's really low in the neck or part or a portion of the subclavian vessels, which is it could be an external jugular and deeply will be a transverse cervical vessels. Midline, we have the thyroid gland and inferior thyroid vessels and veins actually going to the innominate and mediastinum. This is all like a review of the anatomy, of the basic anatomy of the neck. Okay, so now with the introduction of the CT angio, which give us an idea about the CT anatomy, a cross-sectional anatomy of the neck, and angiography, it's been injected a contrast to see the vessels and see if there is any signs of extravasation. And we have the technology of doing a 3D reconstruction of the CT angio as well, so it can give us an idea what exactly extravasated and how bad is the injury to the carotid and jug. That give us more information. So whenever we're doing that nowadays, we don't need to explore however needs not needed to be explored. So the main value of the CT angio is to give you a value about the vessels and how it's injured and how bad it is. It needs to be explored and needs to be prepared with a proper team and proper skill. And as a cross-sectional imaging of the neck, it gives you an idea about other information as well, like if there is a surgical emphysema, if there is an airway or suspected pharyngeal injury resulting into surgical emphysema, then you are prepared when you consider exploration as well. So before doing that, whenever we see a patient of a neck trauma, and again, like they subdivided the zones to make it simple rather than anatomically into a three zone. Zone one, which is if we get a line below the cricoid cartilage between it and the clavicle, will be zone one. And this is where it's critical structures, especially the subclavian, it's hard to be managed surgically alone by a neck team. It needs like a thoracic team or need an intervention radiology if you're talking about really low vessels in the neck and in the chest as well. And level two, and there is a pleura here, and apex of pleura can be damaged as well. Level two, which is mostly approached by head and neck team, and then it will be like a definite overt signs of injury, like a vessels or a midline structures. And level and zone two is between actually the line below the passing by the cricoid cartilage to the line passing by the mandible. And this is the area of interest for most of us. It could be easily clinically seen and explored as well. Scans are useful, but sometimes if you see like an overt signs, you don't need even a scan. You can go ahead and explore it if there is a hard signs, as we will talk about in a minute. Zone 3 is the zone above the mandible, above the line above the mandible, which is a challenging zone as well because this is like a big vessels and the skull base, a big important nerves, lower forecranial nerves and jug and carotid, and actually internal carotid and some of the external carotid. This area is really challenging. If there is a vascular injury and needs to be explored, it's difficult to be explored, to be honest, surgically. Might need a mandibular split, and most of the vessel injury here are managed by intervention radiology. So that's why we divided the neck into zone 1 and zone 2 and zone 3 to make it easier. And most of the problems in zone 1 and zone 3 will be managed, especially the vascular problems, will be managed by intervention radiology team if you have an intervention radiologist in your hospital. However, zone 2 is the area where most of the head and neck and vascular surgery team are joined together to fix any vascular injury in this structure. Zone three, there might be zone one, there might be a rule for a cardiothoracic TB, especially if you're talking about a lung, associated lung or a pleural injury or a vascular injury needs to be sorted by head and neck and cardiothoracic team. Zone one is really unusual to have any input from the head and neck or the ENT team. Usually it's managed as it's a vascular injury by the interventional radiology team. So again, we discuss about the zone and the important instructions, the different zones. Again, I repeat and repeat again. So in zone one, you will see the lower end of the trachea, esophagus, great vessels of the neck, dome of pleura, especially if we're talking posteriorly in the big vessels of the neck, subclavian. Injuries may be hidden, an inspection from the mediastinum and chest, zone 2, which is the most favorable area for our head and neck experience, between the mandible and the cricoid, contains the larynx, hypopharynx, trachea, beginning of trachea, and the esophagus. We have the carotid and jug lateral to the carotid and the vagus nerve, and the other deep nerves, sympathetic chain and phrenic nerves that will be deeper to the deep layer of deep cervical fascia. Injuries are seldom occult. It means that most of them are really presented clinically without even being not being investigated. It could be seen clinically, and you can investigate further to get more information. And it's a very common site for a common carotid artery injury as a stab neck. Zone 3, it's above the angle of the mandible, contains the internal and external carotid, vertebral artery, and lower forecranial nerves. Vascular cranial nerve injuries are really common, and it's unusually to be managed surgically. Usually, interventional radiology team will help with it. Now the question is to explore or to observe. That's a question we have to answer today. When you have to explore and when you have to observe, it's not about penetrating the platysma. It's about that if there is a hard signs of trauma, no time for any investigations. You have to go ahead and push the patient straight away with a very good communication with an anesthetist. If you have an anesthetist in your hospital, a senior one, that will be great. If you have a good anesthetic team or even a junior one, you have a great conversation with a consultant on call or with the team about what you are going to do. Communication here should be quick and should be efficient about what the expectations in terms of management and also for the things that needs to be prepared in the theater or the OR when you consider exploring the patient. So again, if there is it has to mention that before talking about hard and soft science, you have to follow the ATLS protocol, especially when the patient is seen in the emergency. ATLS protocol saying it's advanced trauma life support protocol, A, B, C, D, E. And from E, which is exposure, you will find out about the soft signs or hard signs of trauma. A is an airway. If there is an airway risk, if the patient is not has an airway risk or have a low GCS below 8, you have to consider intubating the patient or securing the airway. So airway security is very important. If the patient arrives talking and no problems, then you have a time. If there is, put him on oxygen. If there is a problem, then you have to secure the airway. And what I mean by secure the airway by a temporary measure or even like definitive measure by intubation if you need to, and then you have the emergency and ITU or ICU team on board and anesthetic board as well on board to get a secure airway. A is airway. Breathing, you have to check the oxygen saturation and check the air entry on both sides because it might have a patient zone 3 neck and has a pneumothorax and needs to be drained straight away with intercostal tube. And there is a debate now about using a needle, if it's tension pneumothorax or getting away straight ahead to get an intercostal tube in the fifth intercostal space in the mid-axillary line rather than the second intercostal space. And you should remember, it's just you go above the rib rather than below the rib to avoid injury to the subcostal vessels. That should be sorted by a cardiothoracic team or an anesthetic, or you as a part of your trauma team, you can learn how to do it. If there is a pneumothorax, not wait until like you get an X-ray. and check the air entry again. C, which is the circulation. It's very important to get the two wide bore IV lines and group and save as well. That's very important. And start fluids resuscitation straight away and group and save because you need a blood if there is a vascular injury and you're trying to control it. So if there is an external sign of vascular injury, as we will mention about the exposure, you have to control it. However, you have to resuscitate really quickly this patient, two wide bore IV lines and group and save. That's very important. Cervical spine immobilization is important with a cervical collar because the more you are moving the neck, the risk may be of a missile injury that could be partially damage the spinal cord or a stab neck. It's really bad enough to have a partial injury of the spinal cord, and then you can transform the partial injury into a complete injury. So cervical spine immobilization is very important. Diagnosis of any neurological disability, and that's important for GCS, Glasgow Coma Scale, to intubate the patient if he needs to. And E exposure, primary survey here in the neck, looking for a hard signs of neck trauma. And and secondary surveys look for other things as well if you have a time. And we go back to the hard signs of neck trauma. We classify it into which is a sign that needs to be immediately addressed. And then you can talk straight away to the anesthetist. I need to go to the theater or the OR to fix what's happening because there is no time for you to investigate further. There is an obvious sign that needs to be fixed. Vascular, which is definitely if there is an active bleeding from the neck, it means that there is a major vessel injury of pulsating bleeding. If there is a refractory shock, despite you are resuscitating the patient, if there is an expanding neck hematoma or a pulsating hematoma, there is a vascular injury definitely is going on, and it's really bad enough you had to fix it. Or a privi or a thrill in the neck, or there is an evolving stroke. That's all signs that the patient is losing consciousness. You need to, and there is a bleeding, you need to go straight away. And the immediate measure, we will talk about it in a minute, how to control the vascular injury until you get into the theater for further control. Laryngotracheal injury, if there is an expanding surgical emphysema, or an active pneumothorax or an open pneumothorax or active bubbling, it means that there is, or a severe stridor, it means that there is a definite airway injury, which is significant enough and needs to secure the airway quickly. And that's preferable to be in the theater because we don't recommend if there is an acute airway injury resulting into a bad surgical emphysema or severe stridor and active bubbling, rather than to get an intubation, is to do a tracheostomy under local anesthesia. That's pretty safer rather than doing an intubation, again transforming a partial cricotracheal separation if it happened into a complete one. A pharyngeal and esophageal injury, if there is a massive hematemesis and a massive surgical emphysema, again that's an indication for an exploration. And that should be as a part of other things as well. It's not the only indication to do an esophageal or a pharyngeal to go straight away and explore the patient. Mainly is the airway and vascular or associated esophageal and pharyngeal injuries with other things. It needs, as a hard signs of trauma, needs to be by itself. Pharyngeal and esophageal injury, massive hematemesis is not an itself. It's unusual, to be honest, in the neck. It's not itself an indication for immediate exploration. If you have a time, then you will go if no hard signs of trauma, which means that no active bleeding, no refractory stroke, no pulsating expanding hematoma, no massive surgical emphysema or stridor, or needs to be addressed, and saturation is fine, and there is just a hemoptysis or hematemesis, then you can go ahead, as it's called the soft signs of trauma. And this is like a less degree of trauma, resulting into, in terms of the vascular injury, you might be presented with non-expanding neck hematoma or hematoma associated with other cranial nerve deficits, like lower cranial nerves or Horner syndrome. Laryngotracheal, if there is a hemoptysis, if there is a surgical emphysema that is not massive, or hoarseness of voice, then again you have time. If it is any pharyngeal esophageal injury resulting into either saliva or a hematemesis or a dysphagia or a neck pain or a dinophagia. And neck pain, especially if there is a neck pain or dinophagia, some hematemesis, emphysema, this is all signs of occult pharyngoesophageal injury, and don't miss it. Usually you have to search for it because it could be missed and could be a cause of mortality in the future. So if there is all of these signs, which most of the pharyngoesophageal injuries are presented with the soft signs, you have still time, you can investigate further. What the investigations we are going to do, the main goal of investigations is to, again, in cases of soft signs, you have time. CT angio is a cornerstone in this area because they give you an idea about if there is any vascular injury and how bad it is. And again, it gives you another information related to the laryngopharyngeal area as well, to highlight the importance of getting an exploration and what you will probably will need in terms of the equipment, and putting a plan for further, getting a plan with other specialties, getting a plan for yourself, what you will need to do if there is a laryngotracheal or pharyngoesophageal injury. So you do a CT angio and go from there. It's worth to mention that if you still have a laryngotracheal injury that is not bad enough, or a pharyngoesophageal injury not bad enough, it's worse before even considering doing a CT angio is to do a flexible nasal endoscopy. So if there is a soft signs of trauma, and also you have a time for a CT angio, you can consider scoping the patient with flexible nasal endoscopy if you have any. That will give you more information about the airway. That will help the anesthetist when you go to the theater, even if it's a small hematoma. If it's slowly accumulating, it can make a compromise of the airway. So let's get an idea about the airway. If there is a pharyngoesophageal or a laryngotracheal injury, then having a look with a flexible nasal endoscopy can give you an idea about the airway. And that's an important information with the CT angio. CT angio is important for you to know how quickly and how bad is the situation and how you can fix it. But the flexible nasal endoscopy actually is more important rather than for you, for the anesthetist, to put a plan for intubation. Intubation could be considered in soft signs because there is no massive laryngotracheal injury. However, as I mentioned, if there is a hard signs with a massive laryngotracheal injury, I prefer to do a tracheostomy. That's a safer option rather than to go for intubation. Okay, so preparation, as I mentioned, is a key, and what by doing assessment to exclude hard signs and understand about there is a soft signs, and doing a scope, a flexible nasal endoscopy, and also having a CT angio, you get the information needed. You know what you are going to do. You know what you are dealing with. You involve the other teams. If you suspect a vascular injury that can be controlled. It's not like, or even if it's a hard signs, you have to talk to a vascular surgery team to be on board. You have to learn how to do a vascular injury and how to control it. However, being supported by a vascular surgeon is not a bad idea, and it's important from the medical legal aspects. Prepare yourself for tracheostomy. As I mentioned, if there is a hard signs of laryngotracheal injury, prepare a vein donor site if you need to do a vein graft, and avoid NG until the airway is secured. That's very important. People sometimes go with the NG. No, you have to secure the airway first. Priority is ABC, and then you go ahead and do anything else. Okay? We talked about secure airway, obtain an airway emergently, intubation or cricothyroidotomy. I will get tracheostomy under local if you have a time, or a cricothyroidotomy as first, my preferred option rather than for intubation. Intubation can be considered if there is a soft signs of laryngeal trauma or soft signs of neck trauma in general, not a laryngotracheal or even a vascular trauma. And you have to know that the cervical spine should be immobilized. That makes the intubation a little bit difficult. And again, if it's a severe laryngotracheal injury, I prefer to do a tracheostomy or under local, or a cricothyroidotomy if we are really in a hurry. Breathing, as I mentioned, there might be a risk of pneumothorax, hemothorax, or attention pneumothorax, and you know how to intercostal tube. Put an intercostal tube. Circulation, as I mentioned, two large IV lines. And then here, how you control the bleeding if there is a hard signs of bleeding. And digital compression is the easy thing to do. If there is an active bleeding coming from a hard sign, until it go back to the theater straight away, you can have by some time by making a digital compression. A literature talking about putting an inflate a Foley's catheter, an 18 French Foley's catheter that can be actually folded on itself to be stable, or the skin over the stab is closed over it. An inflating place could be one or two or maybe more, just to make a stabilized hematoma and seal the vessel until you are exploring the neck formally, and you inflate it with water actually. That's another way of doing it. Until and if it's controlled by then and the patient is stable, you can, rather than to go ahead and explore surgically, if you think that the uh, B, which is circulation, is very stable, no shock. Patient, when there is a hard signs of trauma, it's really controlled with the full catheter, like here, the full catheter is inflated in place. A patient is stable, so it's always a dynamic process. So if there is a hard sign, you know that you are going to go to the theater. However, if you manage things in a certain way that make it stable, like a vascular injury, it's actually better to do a CT angio. However, if it will be a delay and there will be a zone 2 neck, you don't need any more information. However, it's a zone 3 or zone 1. We know like this is zone 1 or then 3. This is a difficult area to be explored, and we need the input of the intervention radiology. So putting a full catheter in place in zone 3 or zone sometimes 1, sometimes like here, it can get you a time to go straight away to the CT angio to get the information needed and to highlight the degree of vascular injury, and if you can do anything externally or you need the intervention radiology either to stent it or coil the vessel. CT angio is the key scan investigating neck trauma, as you see here. This is a CT angio, and you know here there is like a bubbles here. If you can see, there is no evidence. It's not very clear. It's part of the jug is here. Or actually here you cannot see well the like here is the thyroid is a thyroid cartilage, and this um, is or actually this is like a hyoid bone actually rather than a thyroid cartilage. This is the carotid, and you cannot see here very well the jog, which means that there might be an area in the jog. It means, and this is like an expanding hematoma. So that's denoting in the CT angios there is an evidence of an internal jugular vein that can be compressed with a hematoma and the air is in. No air can be in a vessel except if there is an injury. Okay, that's important to know. And we cannot attribute the air here to be a laryngotracheal because it's not expanding into the neck. If it's coming from the laryngotracheal tree or laryngotracheal injury, it will be expanding to involve all the facial spaces. That's another key information as well. And you see here there is an injury to the vertebra, and might be the vertebral artery as well might be affected. So having a CT angio is important because, like again, if there is a hard sign of the trauma and the patient has a refractory shock or evolving stroke, no time, you have to make exploration, except if, especially if it's a zone 2. And then again, zone 2 is neck exploration, no time. If there is, again, patient with symptoms, if you can control it with a full catheter or a compression or whatever you do, and get a CT angio, especially with a full catheter, can get you an idea if you can do something with an exploration or an intervention radiology. However, if it's non-expanding hematoma, slowly accumulating hematoma, it means that still it is in the point of you can investigate further. It's a soft sign. CT angio will give you the information. If it's again zone 3 or zone 1, probably intervention radiology can be okay with that. And exploration here will be only if there is an associated tracheal or esophageal injury. In zone 2, you still can go ahead externally rather than an intervention radiology and explore the neck and see what the vessels, which is probably the jog or partial injury to the common carotid, and you do by neck exploration, you can still control it with the help of the vascular team. So the scheme in your mind. So if there is a hard signs of trauma, and if it's a vascular insult, if it's an airway, like you have to secure the airway with a tracheostomy. That's will be the safest approach. If there is a bleeding, you control it initially by digital compression or a Foley's catheter. And if it's a zone 2, go ahead to the theater to fix it. If it's not a hard sign, or if it's a zone 1 or zone 3, you can control the bleeding first, zone 1 or zone 3, and go for a CT angio. Everything else can go for a CT angio. You still have time to get the information needed according to the area or the zone involved and according to the structure involved. If it's just a laryngotracheal or a laryngotracheoesophageal or even associated with a vascular injury as well. Okay, so how we do if we're talking about a carotid injury? If it's a jog, it will be ligated, no matter. It's you could be still consider repairing the jog with a 5-0 prolin, but if it's a partial injury, but by the time you go to the theater, it will be really compressed, will be really damaged, and when you evacuate the hematoma, it is not easy to be repaired, to be honest. If you can, that's fine, but most of the injuries will result into actually macerated jog, and you will need just to ligate it, okay, basically. And you ligate it, you put a two ties on it and evacuate the hematoma, and you put a drain, that should be fine. If it's talking about like external carotid, euchaligated, if it's a common carotid, which is more common in level 2, then it depends on the degree of injury. If it's just a partial injury, you can suture it continuously with a 5-0 or a 6-0 prolin, actually. If it's like a major injury, a partial laceration, you can put a vein graft or an artificial graft, prosthetic graft. Could be an intervention graft, or you can do an end-to-end anastomosis by using a 6-0 prolin in a continuous matter both sides to fix it. That's again a difficult skill. Not everyone can be doing it. It's important, especially if you're talking about a partial, near complete, or a complete injury to involve vascular surgery team. What you usually do, you put a bulldog or a non-crushing clamp or a Satanisky non-crushing clamp up and down, and then they will try to figure out what's the injury of the carotid, if it's something needs to be repaired, or put a patch graft or interposition graft with a vein, or end-to-end anastomosis. Most of the time, according to the experience of the vascular surgeons involved in such accidents, usually they will end up with the end-to-end anastomosis by doing a good dissection of the carotid proximally and distally. And you might need a vessel loop as well to help to dissect the carotid itself as a common and external and internal, and try to make it free from everything to be able to repair it, or to make an end-to-end anastomosis. That's most of these pictures are coming from this nice um, paper from the South African people, head and neck surgeons, about how to manage penetrating neck trauma. Um, so again, is something in zone 1 or zone 3, or actually in zone 1, probably you will have a big carotid injury, an internal carotid, and probably coiling or stenting or doing some bypass. It's actually a challenge, and most of them, if it's saved, it will be thanks to the luck of the patient and the efforts of the intervention radiology team. That's where they do the actual angio, conventional angio, on how to put a stent or coil it. Okay, if it's a zone 1, then again, if it's like something like related to the pleura or a vessel injury, it can be controlled if you don't have an intervention radiology. You might need a sternotomy, and you need them for a sternotomy and clavicle resection to be able to repair it, to get some proximal and distal control over the vessel. Then you need 3 teams: ENT, vascular surgery, and cardiothoracic team. Usually, most of the zone 2 injuries are managed by head and neck surgery, and we will talk about it in a minute. That's regarding the vascular. And we will talk about the airway, how you manage an airway if it's in zone 2 penetrating. I usually prefer to do a DL as well when I fix it with if it's like really bad injury, tracheostomy under local anesthesia is preferred. and then to secure the airway, and then you can go ahead later and do a DL and have a look for the extent of the damage in the larynx itself, or if there is anything in the hypopharynx. That's all important. Like this is like a picture of a partially penetrating trauma into the trachea and resulting into an emphysema. In this case, the trachea here could be repaired with with absorbable stitches, and it could be partially transected, and it can involve the esophagus as well. If you explore it and you see an esophageal injury, then you have to repair the trachea and esophageal injury in two layers fashion, like the mucosa and inverted it and a muscle on top. And you can get a part of the muscles as well, of the strap muscles or the SCM, just to as an additional layer of closure. And those patients will need to be an NG and sometimes trached as well for 5 to 7 days until they get a contrast to swallow. And this is again pharyngoesophageal. You might need to do a gastrographene if it's missed, but actually most of them will be, if you looked into it, when you explore the neck or you study the CT angio and see there is a tracheoesophageal injury with might be tracheo plus or minus esophageal and explore the area, you will find an esophageal injury, and then you have to repair it. You shouldn't wait until like you get it missed and then you do a contrast to swallow in a few days and found it there is a tear, and because of that, there might be an infection in the neck going to the chest. So the earlier you manage that is the best on the long term to prevent any mediastinitis or um, chest infection associated with a descending neck infection to the chest. Okay, so now we finished about the penetrating trauma and how important it is and how to manage it. And we go to another topic related to the trauma itself. It's a plantar trauma, which most of them will have some time before you can go for the theater, but sometimes it's not that much time, especially if it's a severe tracheoesophageal injury. We talked about the neck trauma penetrating one. It could be either a knife or a stab or a missile or a gunshot. However, if you're talking about the blunt trauma, usually it's a result of either a road traffic accident with a steering wheel stucking into the neck, or it's a clothesline with a belt, or it could be a strangulation. Sometimes it could be iatrogenic if you're talking about a neurosurgery team putting a prosthesis for to fix the spine and then resulting into injury to a laryngotracheal or esophageal mainly structures. So that's again a sort of blunt trauma. When they put the prosthesis, it could be eroding into the or tearing the posterior pharyngeal wall and resulting into some sort of a blunt trauma. Or when you are doing an oesophagostomy and do an or a foreign body actually that is dislodged, it can be sort of iatrogenic or actually an incidental trauma if it's a foreign body going outside the pharyngeal or the pharyngeal wall. We know the anatomy of the larynx. There is a hyoid bone, short and lesser and greater cornea. And we have the thyroid cartilage, which is the most prominent cartilage within Adam's apple. And we have the cricoid cartilage and we have the trachea. Between the hyoid and thyroid, there will be a thyrohyoid membrane penetrated by the supralaryngeal bundle. And between the cricoid and thyroid will be cricothyroid membrane, which is pierced usually by cricothyroid vessels and the external laryngeal branch supplying the cricothyroid muscles. And we have a small ligament between the cricoid and trachea membranes, and it could be injured as well, resulting into cricotracheal separation. History of whenever you have a patient had a history of a blunt trauma, we have few patients been using a bicycle or doing a sport activity and will be steered around it, and they will be presented with a neck injury as a blunt trauma. So what you're looking for, history, it's important to, again, follow the patient ABCD approach. And while you're doing an airway, you're talking to the patient. If he's able to give you information, that would be great. It means that the airway is stable. If the patient couldn't talk or severe hoarseness of voice, or aphonic, or he had a stridor, or he cannot swallow his saliva like a dysphagia or rhinophagia or having a neck or chest pain, that's again something means there is a severe or a sort of severe tracheoesophageal, laryngotracheoesophageal injury needs to be sorted. If the patient can give you some information, it means that it's not bad enough, so you can have some time. So that's A. Breathing as well. Have to check the air entry on both sides of the chest and to make sure there is nothing like a pneumothorax or something, especially if it's a road traffic accident resulting into polytrauma. Circulation again, too wide bore IV9s. It's not usual to have a vascular injury in a blunt trauma. It's not very common. Well, however, you have to do an ABCD approach and diagnose of neurological disability because sometimes it can be happening with a severe blunt trauma and exposure as well. If there is anything of the neck, expose it. And if there is a cervical collar, you have to open it and check the neck to look for signs of blunt trauma. Physical examination is really key here. If there is a stridor, we know that inspiratory, expiratory, or biphasic, to know the level of obstruction. Subcutaneous emphysema is very important. It's very, very important because it could be that the only sign would mean that there is a laryngotracheoesophageal injury, a hemoptysis as well. You're looking for a tenderness over the laryngeal structures or a crepitus and erythema and ecchymosis over the neck. And you look for if there is a contour of the thyroid cartilage, if you can feel it, and associated injuries as well, cervical spine, vascular esophageal injuries. And again, that's subtle. It needs to be have a low threshold for esophageal. If there is an emphysema, you might think about laryngotracheoesophageal injury. That's the only thing that can be presented even with an esophageal injury. And it's usually, well, esophageal injury wouldn't be alone. There will be definitely something coming, usually with a trachea and larynx rather than only an esophageal injury, especially if you're talking about a blunt trauma, externally not a iatrogenic one or related to a foreign body. Okay, so again, patient presented. If the patient really distressed or not airway stable, that's another story. And then we have to go ahead and do a trach under local. That's the safest option. And after that, you can either investigate further or explore in the theater. And the exploration tool here is to do a direct laryngoscopy and bronchoscopy and oesophagostomy to get an idea about any and to visualize the airway, the larynx and trachea, and think about what's going on. If there is a laryngeal hematoma, if there is a big hematoma, if there's a mucosal laceration, if there is a displaced cartilage, severely displaced. This is all like or severe mucosal laceration or associated laryngotracheoesophageal injuries. This is all can be detected when you are getting the patient sorted out his airway and exploring with the DL, a laryngoscopy and bronchoscopy, and also oesophagostomy as well. And you have to repair accordingly, okay? If there is no hard signs, again, here the hard signs is severe airway injury, which is basically A, because we talked about A and B in blunt trauma. However, A, B, and C is important in penetrating trauma. If the airway is stable, you still have time. Don't forget to scope the patient, flexible nasal endoscopy, before considering doing a CT scan. The flexible nasal endoscopy can give you about the good idea about the endolarynx rather than only the external structures, which can be easily assessed with a CT scan. So the flexible nasal endoscopy will give you an idea about if there is a mucosa or a cartilage exposure, vocal cord mobility, dislodgement of the retinoids, vocal cord paralysis, fixed cords. This is all information you can get from flexible nasal endoscopy. And or there is a minor laceration or an edema or a hematoma that needs to be usually managed conservatively, no more treatment. And that can be again assessed and confirmed by a CT. Here you can order just only a CT neck. You don't need to be a CT angio. CT neck is fine because it's unusual to have a vascular injury. CT neck is fine. It can give you the information needed if additional to the scope findings. And usually they said if there is a minor scope findings, we might even not need to go for a CT neck. However, we do it for medical legal purposes. But if you really in a shortage of a CT scan, you might ignore it and just follow up the patient with the antibiotics, steroids, anti-reflux, and just observation. And if there is a mild abnormality, which is a vocal cord immobility or dislodged or excartilage, and because of laceration, you might need to do a CT scan because this is give you more information regarding the state of the thyroid cartilage. And if there is a really bad scope finding, so definitely this patient will need a CT scan. And sometimes when you explore it, you have to think about it. It's really bad injury. So I don't like to traumatize more by doing an intubation. So when that's the case, consideration of tracheostomy under local will be even a safer option before exploring the neck and repair whatever is damaged. So again, airway management. Here is tracheostomy under local rather than even a cricothyroidotomy. Remember, here is tracheostomy under local is safer even to do a cricothyroidotomy because it might maybe the injury itself in the cricotrachea resulting in cricotracheal separation. So it's better to be away from that area, doing a tracheostomy under local if there is a severe airway problem, and then either to do a CT scan neck or to go ahead and explore if this is severe laryngotracheal injury in the theater. However, if there is a time, oxygen, nebulized adrenaline, steroids, and all of this can help. Do a CT scan and after fiber optic intubation to get the full picture, and then you can go ahead and manage in the theater accordingly. So this is like example of the finding. You can see it's here like just a hemorrhage on the vocal cord, and this is a minor hemorrhage. It might not be it might be observed, and this is like some sort of arytenoid bulge, and this is again like a laceration in the vocal cord, and this is like a laceration again in the vocal cord, and might be the case here. The arytenoids are really edematous, and one of them is not mobile. This is all like signs you can get it from the flexible knees endoscopy, and it's really important. Cervical spine, radiological, C-spine, X-ray, that was a traditional thing, but now with the CT is very good. You can get an idea about the C-spine as well. And the C-spine is important, CT is important to get more information regarding laryngotracheoesophageal area itself. And geography is not very common. A contrast esophagogram or a contrast to swallow can be considered, but that's again is not on acute setting. Contrast to swallow, if you need to repeat it, just because if you missed something and this is not the case, or you manage things conservatively and you want to make sure there is no leak, you can order it. However, in the first instance, if there is an injury and there is an obvious laryngotracheoesophageal injury, you should be able not to miss the esophageal injury by doing an exploration, um, rather than just to depend on this and to wait until the contrast to swallow. But some of the subtle injuries you might find you are managed conservatively and still there is minimal findings endoscopically, like with the flexible knees endoscopy. There is some emphysema in the neck with the CT neck. You don't know where the source of injury, patient is stable, then you put an NG tube, airway stable, and you can repeat, you can do a contrast to swallow in 5 days, because if there is any missed pharyngoesophageal injury, then you prefer allowing the patient to start on oral feed. You have to make sure there is no leak, contrast leak. That's an important classification about the degrees of laryngeal injury and how to fix it. Group 1, it's a minor trauma or laceration. No need to be treated in the theater or need to have an airway management. And can be backed up with a scope, as I mentioned. Even the CT will confirm nothing. So you don't need to do CT for that. And then the treatment will be conservative, maybe putting on oxygen instantly, or first, and then you decrease the oxygen need, mobilize adrenaline, steroids, and antibiotic and reflux will be fine. Group 2, it's a moderate laceration and edema, um, but no exposed cartilage, non-displaced fracture of the thyroid cartilage. Again, this can be managed conservatively. Sometimes you can do a tracheostomy, but it's better to be managed conservatively, and then this is again can be confirmed by a CT scan. Group 3 and Group 4 and Group 5, that's a more important. Group 3 is a vocal cord immobility, massive laceration, cartilage exposure. That's again something can be confirmed by a CT scan, and this is something can be repaired if there is a displaced thyroid cartilage, and if there is an exposed cartilage, then it needs to be repaired, the mucosa and the cartilage itself, and stabilize it in place, and that needs to be explored. Again, CT has to be done. If the airway is stable, no rush for tracheostomy. But if the airway is not stable, do a tracheostomy. And most of the cases in group 3, there will be a stable airway to some point of time. So until you get a CT, and you can talk to the anesthetist, put a plan. And the plan here will be either to intubate or to tracheostomize if it's safer, or tracheostomize after you intubate. And then, according to the flexible endoscopy finding, and again, this is an MDT communication. And then after that, you secure the airway and then you repair whatever it is. So if it's like a displaced cartilage, you can repair it, as we mentioned, by non-absorbable sutures, or you can repair it with mini plates and screws. Group 4, which is actually unstable fracture, multiple unstable fracture, and massive laceration. This needs to be definitely fixed, and this is will need a tracheostomy under local. And you might consider stenting because of the massive mucosa that has been damaged. Stented by even, we will talk about stenting in a minute, what's the initial thing, it's in your hand rather than to consider waiting for a Montgomery or an airway stent, a Bulgaria stent. If it's there, it's most of the situations that trauma and you don't find it, you can go ahead and do something similar, and then that save you waiting for a stent. Group 5, we didn't mention it here. It's actually a cricotracheal separation, and that's very dangerous. The patient will be presented with a severe airway problem, massive emphysema. Tracheostomy on the local is the key, and you can even go ahead and explore it in the theater, or do CT scan and explore it in the theater, and that needs to be repaired. Medical management for grade 1 and grade 2. Um, will be just an humidified oxygen, nebulized adrenaline sometimes, and PPI medications and steroids and antibiotics. Surgical management, tracheostomy under local, and then do a DLR bronchoscopy and oesophagostomy. Definitely, if there is a tracheoesophageal, if a laryngotracheal injury, you have to make sure when you explore it externally, if you're doing that, to not to miss any esophageal injury. You can just look into the esophagus, make sure this area is not like bubbling, there is no saliva coming out, there is nothing, and you can be sure like if there is anything happening or not. Needs to be explored within a 24-hour, okay? And the exploration, you will go for a transverse neck incision, and you split the strap muscles in the midline and expose the larynx and look accordingly. If there is a problem in the thyroid cartilage, you can suture it, okay, or you can put a mini plates and screws. That's definitely what you will do. Just repair it with the sutures or repair it with mini plates and screws. And if there is a mucosal laceration, you can repair it with unabsorbable sutures like a vicryl. You can repair the cartilage with a vicryl, although if you can repair it with a prolon, that will be ideal. And if there is a cricotracheal separation, you can go ahead and suture the cricoid to the trachea and put a stent, because this is like grade from 3 to 5 or 4 to 5. Actually, you consider putting a stent to prevent any airway stenosis later. Goal of laryngeal exploration, and you have to debride anything. Primary closure allows the mucosa, repair the mucosa, align the cartilage to avoid any granulation and airway stenosis. Endolaryngeal stenting is considered when there is severe mucosal laceration, and the easy way to do it is to put a finger cut from your gloves, and you just suture it with non-absorbable sutures and fill it with cottonoids, and just put it. You have a tracheostomy under local, so you can put it actually above the tracheostomy until like 10 to 14 days. When you go ahead and do another look with the scope and take the finger cut out and then wean from the tracheostomy. This can be done as a simple way of stenting the larynx. The other way of stenting it could be an endotracheal tube blind-ended, and again that would be a little bit annoying, but it's okay, acceptable. Getting into the level of the larynx from the tongue base of the epiglottis all the way down above the tracheostomy, and you close the end of the endotracheal tube blind-ended. That's again another thing to prevent anything from aspirating. Um, but the finger cut is a very, very, very easy and reliable way of doing it. Finger of the glove and put like a sponge in it and suture it and put it in place that avoid you using a stent and remove it in 14 days. And patient should have a trach for this period of time. And usually the cuff will be up for most of the time to prevent any dislodgement of your and you can put the cuff down. And usually, if the finger cut is very distended, it's unusual to be aspirated or put it down because of the trick. And the way you repair the thyroid cartilage is, as I mentioned, you can get a non-absorbable stitches here, or you can get many plates and screws, and then that can be fixed. If there is a midline injury and severe mucosal laceration, you can repair it with non-absorbable stitches and put a stent and then close it. If there is a cricotracheal separation, you can suture it with with a Vicryl as if you're doing a cricotracheal anastomosis and put like again a stent for 10 to 14 days, and the trick will be cover all of that and then get the stent out, make sure the airway is patent, and wean from the tracheostomy later. But the problem is with the laryngotracheal separation, you might end up, especially if the patient presents with a complete or near complete cricotracheal separation, will be a recurrent laryngeal nerve injury. So you can consider that as well. Whenever you counsel the patient, you will do your best, but sometimes the patient will be presented later with a stridor because he has a bilateral vocal cord palsy. But that's an easy problem. You can get some time with a tracheostomy, and you can do like a laser cordotomy or something just to makes the vocal cord palsy improved. Sometimes it's hard as well in terms of the swallowing because of the recurrent laryngeal nerve palsy, and also for if there is a esophageal injury, then again that something needs to be investigated with video fluoroscopy or a contrast to swallow before considering allowing the patient to swallow eventually. So usually, if there is a grade 3, 4, 5 laryngotracheal injury, usually take care about the esophagus. The least you do is put an NG after you secure the airway and repair your cartilage, because you don't allow the patient to swallow straight away because there is a risk of aspiration because of the nerve palsy, or you don't like to have any aspiration or any tension on the airway. And as well, there might be an associated esophageal injury. If you can sort it out intraoperatively, that's definitely better, and you should look for it. If not, if it's a small problem or it's nothing, NG is a safer option until the patient can do a contrast to swallow, no leak, no aspiration. Then you can start by taking the stent out, wean regarding the swallowing by removing the NG, and following this, remove the tracheostomy eventually. However, there are like complications that can happen. We talked about recurrent laryngeal nerve palsy, which could be an permanent because of either the cricotracheal cricoarytenoid joint dislocation, or if it's actually an injury by injury to the nerve itself, when there is a partial or a complete partial one side and complete both sides, cricotracheal injury, partial separation or complete separation, so one side or both sides. Both sides is stridor and maybe aspiration. One side is just weakness of voice. Granulation tissue, if it's not repaired and not being dealt intraoperatively in the first instance, well, there is higher risk of getting a granulation, a cartilage exposure, and airway stenosis. And that will lead to multiple procedures to deal with the airway. That's regarding the blunt trauma as well. So I hope that we covered both topics and make it safe in terms of the practice. And whenever we're thinking about it's a penetrating airway ABC, you know when to explore zone 2 or go ahead and investigate with a CT angio. Vascular injury is a priority, and laryngotracheal as well. Blunt trauma is usually like a laryngotracheal esophageal injury. Assess the patient clinically is very important. Secure the airway, do your CT, and manage accordingly. Thank you very much.